Dr. Chia is a gastroenterologist with a subspecialty interest in viral hepatitis, fatty liver, as well as other liver-related disorder. Prior to joining us at gutCARE, he has been practicing clinical hepatology and general gastroenterology for 14 years in Dundalk hospitals. And previously, when he was in Dundalk Hospital, he was actively involved in various forms of research as well as clinical education. Without further ado, I'm going to proceed and pass the floor to Dr. Chia, who is going to talk to us in a lot more details about these topics of hemorrhoids, a pain in the bum. Dr. Chia, please.
Hi, thank you for joining us today. So today we talk about hemorrhoids. So these are our sponsors. So introduction, symptoms of hemorrhoidal disease when patient comes to see us includes per-rectal bleeding, anal pruritus, itch in the bum, right? Prolapse, so sometimes they say, oh, there's a lump in the bum. And pain is usually due to thrombosis of the external bowels. In actual fact, hemorrhoids are normal vascular structures. And in other words, if you say hemorrhoids, everybody have hemorrhoids. That's just part of the normal vascular structure. But when you say hemorrhoidal disease is when the normal vascular structure is swollen and it causes symptoms, right? External hemorrhoids are hemorrhoids that are distal to the dentate line, and internal hemorrhoids refer to the hemorrhoids that is proximal to the dentate line. So if you look at the anatomy, right, pay attention here to this curvy line here. This is the dentate line, right? And the hemorrhoids that are above this line are the internal hemorrhoids. Below this line is the external hemorrhoid. And the way the vascular structure is organized is such that when hemorrhoid occurs, there are three columns, one on the left. So this is normally known as a left lateral, and two on the right, one posterior and one anterior. This is when they are on the lithotomy position. But when they are on the left lateral position, you have one that is inferior, there's one on the left, and two that are above. So one, it will be a Y shape, right? So always remember that hemorrhoids comes in this kind of configuration. Another way to say is that if there are lumps that are not in this position, they may not be hemorrhoids. You need to think about other things. The classification of hemorrhoids is important because we treat according to the treatment modality follows the classification. Grade 1 hemorrhoids are those that do not prolapse. Grade 2 is a prolapse, but they can be reduced spontaneously. Grade 3 prolapses and needs to be pushed back in, and grade 4 are irreducible. The prevalence of hemorrhoids are difficult to ascertain. It's reported to be, some reports say 3%, 4%, 5%, and some can be as high as 39%. So sometimes you read magazines that they say, oh, 1/3 of the people will suffer from hemorrhoids. Actually, when it comes to symptomatic hemorrhoids, the disease, right? In other words, people with hemorrhoids and then some bleeding, some itch and so on, is probably closer to about 5%, right? But if the studies are done like looking at endoscopic findings of presence of swollen hemorrhoid, then the number will be closer to 30+%. Part of the reason is that the hemorrhoid, the hemorrhoidal structure does get a bit swollen after some diarrhea. And a lot of patients, after they've gone for colonoscopy, when they go for colonoscopy, they have bowel prep. And the bowel prep, they probably pass motion like 10 times. So the hemorrhoidal structure sometimes can be a little bit more swollen than usual. And if you do colonoscopy, you do a retrospection, you'll find that the internal hemorrhoids may well be a little bit swollen. So that may or may not cause disease per se. So if you look at the studies that report 31%, chances are they are looking at patient with or without symptoms, and they're looking at endoscopic evaluation. Most studies report that it's equal in both gender, but in our experience, a lot of women postpartum who have very troubling hemorrhoidal disease. The peak of the disease is between 45 to 65. The implication of that is that if the patient is too young, below the age of 20, they are quite unlikely to have hemorrhoidal disease. And likewise, if elderly come with per-rectal bleeding, someone that is 70, 80 years old, say, or PR bleeding for the first time, it's also quite unusual to be hemorrhoidal disease. You do have to look for other causes. So some studies says that many patients with hemorrhoids are asymptomatic. You can almost say that this even disease to start with, because like I said, hemorrhoids are normal vascular structures, right? So if they do present, how do they present? Some of them present with hematochezia, meaning blood in the stool. Some of them present with thrombosed hemorrhoids, and then that will be painful. So it's a painful lump. Patient may have perianal pruritus, right? Sometimes may have fecal solidage, mucus discharge, wetness, or when it's prolapse, a lump in the anus. So the hematochezia from pulse. Okay, so maybe a word on the clinical manifestation. Not all the symptoms need to be present. So quite a lot of patients will present with hematochezia alone. Some will present with pain alone. Some will present with pruritus alone. Some will present with just fecal solidage and mucus and without much hematochezia. Some patients will have a combination of these symptoms. Okay, so it's not unusual to have just one symptom alone. The hematochezia from pulse is almost always painless. So it's associated with bowel movement. So after passing motion, then they say, oh, there's blood, right? Or it can pass spontaneously without a bowel movement. It's bright red. It can be dripping from the anus. And this can be exacerbated by straining. And if it persists long enough, sometimes they may cause iron deficiency anemia. When it comes to hematochezia, in other words, bleeding per rectum, if it is associated with pain, it is much less likely to be hemorrhoids related. So if the patient says it feels like, when they pass motion, feels like a knife is being put into the anus, that's most likely anal rectal fissure rather than hemorrhoidal disease. If let's say they have this sensation of urge and some lower, there's some discomfort when they pass motion, quite often this can be proctitis, but rarely proctitis can be painless as well. Sometimes it's trauma in the hospital. Sometimes when they insert things into the rectum, they can cause trauma and bleed. Personally, I've seen patients that put all kinds of things into the anus, and some of them do not give you the history, and they do cause anal bleed as well. They cause per-rectal bleeding. Sometimes can even cause perforation. Some of the other conditions that may be painful or may not be, such as solitary rectal ulcer syndrome. This is a condition where there is abnormality in the movement or during defecation, when the movement of the lower structures are not coordinated, causing stress in the mucosa and causing ulcer, they may bleed. Like I mentioned earlier, ulcerative proctitis sometimes can be painless in a milder form, but more often they have diarrhea, and more often or not, they have this incomplete evacuation feeling. They have some feeling most of the time, but sometimes they are painless. Sometimes, rectal neoplasm adenocarcinoma can be painless. Also, typically painless bleeding per rectum is rectal adenoma, sometimes lymphoma, other Kaposi sarcoma, or that also can be painless. Anal dulophoid lesion is painless bleeding, right? Rectal ulcers, some rectal ulcers are painless. Stachoral ulcers are painless. Radiation-induced Proctitis can be painless. Itch-related ulcers can be painless. Diverticulosis bleed is almost always painless. Some patient on warfarin may have bleeding, and if you do a scope, you see that it's inflamed, it look inflamed and it's bleeding. Post-procedure, post-polypectomy and all that can bleed lah. Of course, upper GI bleed in severe enough, you can get the PR bleeding as well. The itch that is associated with pulse results from mucus deposition on the perianal skin. And the prolapse of the internal hemorrhoids also permits leakage of the rectal content, causing irritation and itch. Sometimes the itch can result from unhygienic skin tags, because when the skin tags, unless they wash, they are unable to clean it properly with paper. Quite often, aggressive cleaning may also irritate the perineum, causing itching. So one particular reason why they itch is when they use soap to clean, and then the soap dry up the perianal skin, and as a result can cause itch as well. So usually when someone is having itch, you ask them to clean, with water, not with soap. So if they die have to use soap, you have to make sure that they clean the soap properly. And excessive dry cleaning may cause dry skin. So sometimes when you inspect the perianal area, they may look like there's some cracks and dry and all that. So those are rectal, anal, perianal eczema even. So those are very itchy, and you need to use steroid cream for those. So itch is definitely a symptom of hemorrhoids. So when you take a history, what do you ask for? So you make sure that it is painless passage of bright blood with bowel movement. You do have a screen for other symptoms. Quite often, patient come to you will say, I have pulse and I pass blood. Right? Don't straight away give a prescription of Teflon, because you need to ask, do you have fever? Do you have weight loss? Do you have abdominal pain? Is there a change of bowel habit? And so on, to make sure that you're not missing a more sinister diagnosis that is associated with hematochezia. Past medical history can be relevant also. Was there previous history of GI bleed previously evaluated? Is your anticoagulation? And is there history of IBD, previous radiation, psychiatric history, and social history as well, family history of malignancy. So actually, the history taking for hematochezia, you need to make sure that you cover not just pulse, but all the differential diagnosis of hematochezia. So when you examine, first thing you do is inspection. Inspect the inner verge and the perianal area. A lot of patients say, I have pulse. Then when you go and have a look, you see, it's indeed pulse, prolapse pulse and all that. Sometimes when the patient comes, they say, I have pulse. You go and see, you see something else, right? Or now, if they say, I have a very, very painful lump, and you go and see, you see this is a thrombosed external hemorrhoid. So the lump there is where the external vessel, inside there is a blood clot. It's actually very tender. It's most tender for the first 3 days or so. And then after that, the clot organizes and shrinks, and the symptoms gets better over 7 days. So this is the natural history of thrombosed external pulse. Sometimes you examine, you can see anal fissure, right? And you can see some patients say a pulse, examine is actually a perianal abscess. So you do have to examine the patient even when they say they have pulse, because if say someone has perianal abscess, they say they have pulse, you give them pulse medicine, they're not going to get better, they'll end up with a problem and you can get into trouble for it. So all patients that say they have pulse, ask for treatment, best that you examine them properly and make sure that it is what they say it is. And anal condylomata, you have to screen for sexually transmitted diseases and so on. If you see this, this is not pulse, this is sexually transmitted disease. Then, of course, if they say they have pulse and bleeding, you do have to do a per rectal examination. Palpate for mass, look for cancer of the anus, cancer of the rectum. If there is any perianal mass, look for fluctuance for perianal abscess. Any tenderness, Of course, if the patient say it's extremely tender, you may not want to stick a finger in. Just look, maybe if you just look carefully, there may well be a fissure. You put a finger into an anus when there's a fissure, the patient's not going to like you. It's very, very painful, right? And it's also good that while you are at it, characterize the anus sphincter tone. So a lot of time, pulse is associated with the increased anus sphincter tone, so you feel that it's very tight now. When that happens, when you carry out the next part of the examination with proctoscopy, you do have to warn the patient that it can be a bit uncomfortable, because when the anus sphincter tone is tight, this is a bit uncomfortable. And also be aware that proctoscope is slightly, there's a slight slope to the proctoscope. So when you examine, you ask the patient to breathe deeply in and out. You slowly insert it, pointing towards the umbilicus, right? And as you withdraw to look at it, right? Sometimes what happens is that, so you do want to look for pulse. Most of the time we do it on the left lateral position, right? So on the left side is the inferior side. So you are looking for pulse from the bottom, right? And then you see it's a Y, you're looking for Y. So looking at pulse, right? Now, if the anus sphincter tone is tight, and you're not careful, as you withdraw, right, the tight anus sphincter tone can literally just push out your proctoscopy straight away, and then you can't see properly. And then if you do it again, the patient's not going to like you. So just be very wary of that. So because a lot of patients with hemorrhoids, their anus sphincter tone is tighter. So as you withdraw, right, you kind of have to put some force and withdraw slowly, okay? And make sure that the thing doesn't get pushed out by the strong anal tone, so that you can see properly, right? And the place to see is between 4 cm and 2 cm, right? So you kind of know that your how far you insert, right? So between 4 cm and 2 cm is where you see the internal hemorrhoids. So about 2 cm is where you see the dentate line, right? And then you just slowly withdraw. So the key is do it very slowly, right? You look for the pulse at the 3 position. If it's left lateral position, it's at the 6 o'clock, the 1 o'clock, and the 11 o'clock. And then you also look out for any bleeding spots. Sometimes you can actually see the spot where it's bleeding. Now, the bleeding spot is below the dentate line. Then is external pulse. If you go and ligate that, it's going to be very painful. So also try to see where the bleeding spot is. It above the dentate line or below the dentate line? Is it deeper than 2 cm or is it shallower than 2 cm? So after proctoscopy, then you come to a diagnosis of his pulse. Honestly, of all the GI conditions, hemorrhoids is a pain. Pain because number one, patient can be quite worried. No? They come, they are very worried. They can be very fearful. Is it something serious or not? It's quite a scary thing. Look at your toilet bowl, it's all blood. And so patient can be quite anxious. So you have to manage the emotion. For some other patient, may not be serious, but very itchy. Or the lump is bothering me very much. I can't wear my underwear and the soilage and all that. So there's significant drop in quality of life for some of these patients. So the patient come in already quite unhappy because of the pulse is bothering them. But the pain for me is that hemorrhoids, the diagnostic traps abound. There are a lot of diagnostic traps because hematochezia has a lot of differential diagnoses. So a lot of other conditions may present hematochezia. So if not careful, you say, oh, well, maybe it's pulse, then it turned out to be something else, then it's very difficult for you. So, and a lot of time, even when you examine and you see the pulse, but you do not see active bleeding, you also are not very sure whether the bleeding was indeed from the pulse, because it may coexist with something else. And sometimes you another diagnostic problem is that remember I said that hemorrhoid is normal, right? So some people that no symptoms and a bit of solid hemorrhoid, you may not want to call it hemorrhoidal disease. So I recall that I did a scope for a man, someone for other indication. It wasn't PR bleed, that was something else, right? Then when I do the scope, I saw that the hemorrhoids is minimal swelling, right? So I said no hemorrhoids because or minimal. So minimal, sometimes you don't report, just say it's normal, right? And there's no symptom, no PR bleeding. Then after the colonoscopy, when you report no hemorrhoids, right? And then a couple of years later, you say, oh, I passed blood. Then you say, oh, okay, I think it's not likely to be something serious lah. Scope just done 1 year ago, right? And you say, oh, is it hemorrhoid or not? Possible hemorrhoid lah. But last time you say you don't have. It's like, it kind of catch you lah, because while there's no symptoms, right, you are hesitant to call it hemorrhoidal disease while there is hemorrhoid. And then because you don't call it a disease, then when they come back again, then you kind of, oh, is there or is there not? So that kind of diagnostic dilemma exists, right? And also, if you read guidelines, you'll say, oh, guided by age, so older people go for scope, younger people don't go for scope. But younger people also have diagnosis other than hemorrhoids. So you assume that someone has hemorrhoids. Sometimes you can be wrong. So that's the problem with hemorrhoids. There's a lot of diagnostic traps, right? And the other pain about hemorrhoids is about treatment. Sometimes the morbidity of treatment can be worse than the disease itself, because a lot of times just bleeding, and the bleeding is small amount. Actually, if you minus the fear, it doesn't interfere with quality of life that much. The bleeding is small amount, for example, right? Then you go and do a office-based ligation, and it happens to be a bit near the dentate line, hard base, severe pain, after that. Sometimes you think you do okay. After procedure, they say no pain, no pain. Go home, they say a lot of pain. Oh, damn jialat. Then, so the morbidity of treatment sometimes can be worse than the disease itself. So sometimes someone just have a bit of bleed, slight prolapse, doesn't cause a lot of problem. You're going to do bending, right? Next day, come with thrombosis of the external pulse after you ligate. Oh, the thing then pain. That is a problem. So sometimes the morbidity of the treatment, right, can be worse than the disease itself. So you have to be very wary of that. It can happen. So the communication with the patient is key. So you have to let them know what you can achieve, let them know that can recur, let them know that, oh, ligation, these are the possible complications. What happens is like that, what happens is like that. They need to be very clear before you offer your office-based treatment and all that. Then the other thing is recurrence. So a lot of time you do, you think you did a good job, then 1 or 2 years later, 3 years later, oh, you come back again. So even surgery have recurrence. So in other words, it's really a pain to manage properly. One question I get asked is that, do I refer or do I treat? I guess you should refer for endoscopy if there's suspicion of upper GI bleed, meaning it's not bright red, it's dark red, right? And if they are vital, if they are hemodynamically unstable, regardless, they should come for scope, right? And if they're melena, they should go for upper endoscopy first, and then followed by colonoscopies. If there are any symptoms suggestive of malignancy, change of bowel habits, anemia, loss of weight, or abdominal pain, then they should be referred to exclude upper or lower GI malignancy. If the fecal occult blood is positive, it should be referred for colonoscopy. Fecal occult blood in the hemorrhoidal bleed should be negative. Positive family history of malignancy, you are better off referring them for endoscopy. Treatment-wise, if usually start with conservative treatment, but after you have tried 6 weeks of conservative treatment, meaning medication and change in diet, lifestyle, all that, you can consider office-based procedure. So some of you do ligation in the clinics. and some of you don't. If you do not do ligation in the clinic, you may refer on to us or to colorectal surgeon to do ligation and so on. If they're symptomatic grade 3 or 4, meaning you need to manually reduce or is reducible and they're symptomatic, they should be referred for treatment. Usually these are referred to the surgeons. Thrombosed external hemorrhoids in the first 3 days especially, you refer to a colorectal surgeon for surgery. What about age? If you go to some guidelines, they'll say above the age of 40, you should refer, and there's PR bleed, you should refer for colonoscopy. Locally, SGH published a paper in 2020. They look at 453 patients with hematochezia, meaning PR bleed, as the only symptom, as indication for scope for patients below the age of 40. They found that the incidence of adenoma about 7.4%. Okay, and the alternative diagnosis to hemorrhoids, colitis about 3%, diverticular disease about 2%, fissure 1.2%, which is quite amazing. Fissure with no pain, just hematochezia. It's a bit funny, but that's what they reported. IBD 0.4%, rectal ulcer 0.4%. In other words, the mass majority are still hemorrhoids, but as hematochezia is the only presentation, you do get substantial number. There are other things. So if you add all the numbers, right, probably more than 10% is something else. So based on this, the author recommend colonoscopy for Asian patient above the age of 30 for rectal bleeding as the only symptom. This is a SGH paper. So some case that I can share with you. This one, 22-year-old previously healthy woman, multiple episodes of fresh PR bleed, multiple and not treated because assumed to be hemorrhoids are treated as that. The colonoscopy showed this lesion. Actually, this is a diploid lesion. It's an abnormal arterioles that spurt bloods. Treatment is to do endoscopic treatment, clip or burn. 33-year-old Indian Muslim male, blood in stool for 6 weeks, fresh blood, constipation, more blood, sounds like house, right? No pain, right? Colonoscopy showed ulcerative proctitis, and that's the cause of the bleed. So sometimes you get caught by things that you thought is bowels or prepared for bowel treatment going into something else. Having said that, I would say that most of the ulcerative proctitis may have some other symptoms, which the patient may or may not report to you. Lastly, we come to treatment for hemorrhoids. Treatment for hemorrhoids basically can be divided into conservative treatment, and then the office-based treatment, and then surgery. So let's start with the conservative treatment. So first is diet modification, right? They need to go on a high fiber diet. So high fiber diet has consistently been shown to help with hemorrhoids. So there are good quality studies, quite a number of them, that says that high fiber diet helps. But the high fiber diet, right, needs to be high enough, and it needs to be for the duration of 6 weeks. So it's not an immediate fix. It takes time for symptoms to get better, both for itch as well as bleeding. So the recommendation is 20 to 30 grams of fiber. That's a lot of fiber. So practically, how do you tell patients to eat so much fiber? Basically, add beans, lentils, raw oat, and nuts into their diet. These are all very high fiber food. Half the food that they consume, half the plate should be vegetable, right? And the grain, right? Instead of rice, they eat brown rice, right? Instead of bread, they eat wholemeal bread and so on. And on top of that, you eat fruits. So when you eat like that, right, you're more likely to get enough fiber in your diet. If you search online, how do I eat 20-30 grams of fiber a day, you end up with something similar to this. Of course, some patients say, I cannot eat so much fiber. What do I do? So there are commercially available fiber supplement, things like fibrogel, fibrosol, and all that, it can be helpful. Like I said, it takes about 6 weeks to see beneficial effect. So if they want to, but this is something harmless, so should be recommended for almost all patients, right? And while they take so much fiber, then they should make sure that they have adequate fluid intake. So they should take about 1.5 to 2 liters of water. Now, there's an exception to this. There are some patients, right, that has a slow transit constipation. Okay, so the clue is that they will say they pass motion once in a long while, once in 4 days, once in 5 days, once a week. Very difficult, or they need like laxative all the time. If you ask them to eat this much fiber, the constipation actually get a lot worse. And when the constipation get worse, the hemorrhoids will get worse. So this doesn't apply to those type of patients. So when you want to recommend high fiber diet, beware of a subgroup of patient with quite severe constipation. The high fiber may worsen their constipation. Okay, so just be aware of that. Other lifestyle changes: refrain from straining, refrain from sitting on the toilet bowl for too long, regular physical exercise, avoid medication that causes constipation or diarrhea for that matter. Limit the intake of fatty food and alcohol, which will worsen constipation. Teflon is a quite commonly used medication, right? For acute hemorrhoidal attack, you can use 1 gram TDS for 4 days, and then 1 gram BD for 3 days, and then 1 gram BD till they are better. This will improve itch and bleeding. Teflon in the market comes in 2 formulations, either a 500 milligram or a 1 gram formulation. So 1 gram TDS for the 1 gram tablet will be just 1 tablet 3 times a day. But for 500 one is 6 a day. So 2, 2, 2, right? So just dose accordingly. There are a lot of topical things we can use. Generally, they have something like phenylephrine to shrink the hemorrhoids, some lignocaine to numb the hemorrhoids, and some steroid to reduce the swelling and make the skin better. If they have steroid, it can be helpful for the eczema associated with the hemorrhoids. And there are a lot of them in the market. A lot of them are over the counter, and they're not the same. Let's say, for example, a very recognized brand for hemorrhoids is Preparation H. Look at Preparation H. There are not one of them. There are many of them online, and they have various combination of what's found in them. If they have no steroid, maybe less effective for itch. And if there's lignocaine inside there, they'll be more effective for, so you really look at what is inside there. Some of them are like all the natural thing. Yeah, so patient before coming to see you, probably they've tried one of these or other. So you ask them, what have you tried? Or this one doesn't work. Okay, maybe I'll try something else. Yeah, sometimes you may not be able to get hold of certain things that you want. Like recently, the proctosidal suppository out of stock, cannot find. So sometimes this problem is some patient, or when you do a physical examination, or we do the per rectal examination, you find that the inner tone is very tight. And you do the proctoscopy, your proctoscope is almost expelled by the inner tone of the type. Giving them a bit of nitroglycerin ointment may reduce the anal sphincter spasm. It may help to control some pain and itch and even bleeding. The trouble of this rectogesic or any similar nitroglycerin ointment is that it has a side effect of causing a headache. So tell a patient that if you apply this, you will get a headache. Usually it will go away after the second or third day. You stop applying, then you apply again, you get a headache again. So this you need to tell the patient that. So when the anal tone is very tight, this can be helpful. The other simple thing that can be helpful is a cyst bath. The general idea of cyst bath is put your hemorrhoids into warm water with or without salt for 2 times a day for 15 and 20 minutes. How that is achieved, there are two. If you have a bathtub, you can fill the bathtub with warm water and then put a bit of salt and then sit in the bathtub. If you do not have a bathtub, they are over the toilet bowl tray, like what I've shown here. And then you just put warm water, 1 or 2 teaspoons of salt, sit 2 to 3 times, and each time 15 to 20 minutes. So how much salt? Actually 2 teaspoons of salt, normal table salt is normally good enough. Sometimes warm water alone also good enough. Of course, there are high-class salt. Some of them will go online and buy cyst bath salt. They can be quite expensive. So, but this is a simple method that helps with helps with the spasm of the internal sphincter muscle, and they can get quite a bit of relief from cyst bath alone. Don't forget that a lot of times hemorrhoids worsen by constipation and diarrhea. So if you don't address the constipation and diarrhea, then problem will not be solved. Okay, so because both constipation and diarrhea can worsen the hemorrhoid. So if they have a lot of hard stool, consider stool softener or like lactulose, amitiza, right? If they're diarrhea, in addition to address the diarrhea, you may need to think of alternative diagnosis. So in other words, what's causing the diarrhea and the bleeding, for example. So beware that it can be, for example, inflammatory bowel diseases, right? And if you take the history, there's quite a bit of change of bowel habit. Always beware that this could be a change of bowel habit associated with Chia rectum and something like that. And don't forget that patient get too constipated, they can get spurious diarrhea. So sometimes you examine the tummy is very, very bloated. Do a simple x-ray, fecal loading, but they're having diarrhea, that's spurious diarrhea. Next thing I want to emphasize on is when you do office procedure, some of you do rubber band ligation of the pulse in the office. I think the key is that you need to explain to the patient what you will be doing, and then manage the expectations and help them weigh the benefit and risk of conservative treatment versus office procedure versus surgery and so on. And like I said, complication of even office-based procedure can cause significant suffering and discomfort. Some of them are self-limiting. Some of the complications, just a bit tight for 3 days, but it's just very annoying for the patient. So if you don't tell them, you do a ligation, then they are tight bound for 3 days, they won't be very happy with you. And there are people who get complaint all the way to SMC for hemorrhoid treatment. It can cause substantial amount of unhappiness. So you have to be very cognizant of that. And when you want to take consent to do procedure, you need to really explain yourself very well. Communication is key. Just beware that complications of pulse treatment can be worse than the symptom of pulse. That's something to be wary of. Let's talk about rubber band ligation. So there are various ways you can do it. There are those that you use the wall suction. Those that there are this thing that you can do a gentle suction using a hand. Those that use forceps, right? Usually used for grade 1 and 2 internal hemorrhoids. It cannot be used to treat external hemorrhoids. So if the thing is closer to the surface, below the dentate line, must not treat those. Those can be very painful. So in other words, right, when you do the proctoscopy and try to ligate, right, if it is 2 cm and nearer to the anal verge, right, be very wary. Those better off not like it because it's very painful, right? And if as you put the rubber band, if the patient complains of pain, you're in the wrong place lah. Also, sometimes in the office, usually they are not sedated, so they are awake, right? So when you suck, the patient shows that she's in pain, start moving all that, then probably don't release the rubber band. So one way you can do it is that you put in a proctoscope, right? You put in the ligator, right? You position yourself, right? Then you suck. After you suck, you ask the patient, how are you feeling? You feeling okay or not? Okay. Then you fire. And if you do that and patient say okay, and then you fire and no pain, then usually you are okay, you're in the right place lah. Trouble with sometimes when we do it as part of the endoscopy procedure, the patient sedated then you won't know whether it's painful or not until you wake up. So for people that do endoscopy and ligation, we need to be extra careful. Rubber band ligation is contraindicated if they are on anticoagulation because when the rubber band drop off, they can have significant amount of bleeding. That includes patient that is on Plavix. So must take a medical history. Make sure they are not on no ad for atrial fibrillation. Make sure they are not on Plavix. They're also relatively contraindicated in the patient that are immune compromised because they are at higher risk of bleeding, right? And like I said, it must be placed 5 millimeter above the dentate line. And the dentate line roughly is about 2 cm from anal verge. Okay, so if you do enough proctoscopy, just try to learn how to find the dentate line. That will be helpful. It's about 2 cm in. So complication or rubber band ligation reported anywhere between 8 to 80%. Don't forget that after the ligation, next day patient can have hemorrhoidal thrombosis, external hemorrhoid thrombosis. They can get localized infection or abscess. So when patient post-procedure asks for consult, please make sure it's a proper consult, not a teleconsult. Come, examine, make sure they don't have a thrombosed hemorrhoid or abscess and all that. Some patient can have sepsis, urinary retention, also part of the complication. Success rate will decrease with longer follow-up. In other words, over time, they will recur. Sclerotherapy is when you inject 1 to 3 ml of sclerosant into the submucosa plane using a spinal needle or 21 gauge needle, usually used to treat grade 1 and 2 internal hemorrhage. The advantage is that sclerotherapy has less bleeding risk. So because they have less bleeding risk, you may do them in the patient with anticoagulation and Plavix and so on. But you must inject the sclerosant in the right plane. Otherwise, it can cause bad infection and so on. HET is something that I use. It's called hemorrhoid energy treatment, right? So the basic idea is that you insert this particular instrument and you try to catch the hemorrhoidal artery, and then you apply this bipolar energy to the hemorrhoidal artery and occlude the artery. And as you do that, the internal hemorrhoid over time will shrink. Right? It is safe, it's effective, it's painless. Only trouble is relatively expensive. So that plastic contraption costs a few $100s. So this one usually, it can be done in the clinic without the endoscopy part. It can be done without sedation. But usually I do it with sedation at the end of the colonoscopy. So we do this quite often. And the result is quite good. So much so that these days I use mainly this rather than ligation. Ligation on and off, they'll have more bleeding and more pain. So we much prefer this. Basically, it's safer and it's just as effective. Don't forget that some patients need to go for surgery. So for external hemorrhoids, if they're not causing symptoms, can be left alone. If they cause a lot of symptoms, pain, thrombosis, and so on, refractory to conservative treatment, then you may want to refer them for surgery. Large or severely symptomatic external hemorrhage, like severe pain, interfere with hygiene, the skin is irritated, and all, yes, please get the surgery and remove it. And if there are a lot of skin tags, the only way to get rid of skin tags is surgery. And if they have both internal and external hemorrhoids, and the external hemorrhoids need surgery, might as well use surgery to treat both. And symptomatic external hemorrhoids in the presence of other anal rectal conditions that need surgery, probably better off going for surgery. So a little bit on the thrombosed external hemorrhoids. The treatment is an acutely painful purplish and blue mass in the perineal area. Most painful in the first 48 hours. And in the third day, they organize and contract. The symptom will start to go down. Occasionally, the thrombus evacuates spontaneously, leaving behind an ulcer that heals over time. If they present the first 72 hours, it can be treated with excision, meaning you remove the entire thing, right? The recurrence rate is about less than 20%. If we just make a nick and remove the blood clot, the recurrence rate can be as high as 30%. For surgical treatment of internal hemorrhoids, usually we recommend for grade 3, especially if it's more than one column. Grade 4 are irreducible ones. Those that failed conservative and office-based procedure, and presence of both internal and external when external needs treatment. So this is surgical treatment for internal hemorrhoids. What do they do for treatment for internal piles? Generally speaking, there's no ideal treatment, right? The conventional hemorrhoidectomy has the highest complication rate, most painful, and has the lowest recurrence. Whereas the hemorrhoidal artery ligation has the lowest complication rate, least painful, but highest recurrence rate. And then the simple is modest, so it's modest complication rates and modest recurrence rate. So staple hemorrhoidopexy, right, does not deal with external piles. So all those things about concomitant external, it doesn't apply. And hemorrhoidal artery ligation also does not deal with prolapse. Basically, it's like the HET I mentioned earlier. They use Doppler to find where the artery is, then they will ligate the artery. And after ligating the artery, it is effective in shrinking the hemorrhoids. And closed hemorrhoidectomy is when they close up, whereas open, they leave it open. So the healing is a bit faster, it's less painful. There's this new instrument called a ligature hemorrhoidectomy. It's less painful, but it's more expensive using the instrument. So those are the outline of surgical treatment for internal piles. Surgical complications depends on which procedure was chosen. Quoted as 1 to 2% bleeding risk, quite often that they get urinary retention. There's UTI risk, right? Rarely they get fecal incontinence and anal seizure. They're rare, not so common, right? So the take-home message is hemorrhoid is a common problem, so we all need to be familiar with it. There are enough diagnostic traps, so beware of multiple pitfalls in diagnosis and management. Conservative management sufficient for most of them. Lifestyle changes, diet changes, a bit of Deflon, a bit of Proctosidal. Most of the time does the trick. And we have to work in partnership with gastroenterologists and colorectal surgeon. Refer for endoscopy for gastroenterologists, and for them, some of the pulse treatment, the colorectal surgeon may be able to help. Thank you. Yeah, that's all I have to share. And next few talks, 22nd of September, my colleague Jared will be talking on colorectal screening. 29th September, Ruben will be talking about belching and bloating. And Han Ho will be talking about chronic diarrhea, in 6th October.